Every single day, people come into my office convinced their eyes are fine. They had their prescription updated 6 months ago. They passed the eye chart. Their optometrist said everything looked normal, and yet they sit across from me describing symptoms they have been living with for years. Difficulty reading in the evening. Trouble adjusting when they walk from outside into a dim room. Colors that seem slightly faded on one side. Headaches after an hour on the screen. The first question I ask is always the same. Walk me through a typical day. What you do from the moment you wake up to the moment you go to sleep. And that is where things get interesting, because the problem almost never is that these people are ignoring their eyes. The problem is that 7 specific daily habits are working against their vision every single day, and nobody ever told them. After 50, your eyes do not have the same margin for error they had at 30. The lens stiffens. The macula becomes more vulnerable to oxidative stress. Blood flow to the retina becomes less efficient. The cornea takes longer to recover from strain. Habits that your eyes absorbed without consequence at 35 now produce measurable damage at 55. The same input, a different biological response, and the 7 habits I'm about to walk you through are the ones I see driving real, progressive, largely preventable vision loss in my patients week after week. Subscribe to Dr. Rubens Senior Health right now and hit that like button. What you're about to hear is not going to come up at your next appointment. Eye appointments are built around measuring what your vision is today, not around teaching you what is quietly eroding it. The system profits from prescriptions and procedures, not from the conversation I'm about to have with you. Before we go into the 7 habits, I need to establish one thing clearly, because it changes how seriously you take everything that follows. Your retina cannot regenerate. The photoreceptor cells lining the back of your eye, the rods and cones that convert light into vision, do not replicate the way skin cells or blood cells do. When they are lost through disease, through chronic oxidative stress, through sustained damage from any source, they are gone permanently. This is not like a joint where you can rebuild cartilage with movement and the right nutrition. This is not like a muscle where you can reverse loss with resistance training. Retinal photoreceptor loss is irreversible. The reason this matters is that every habit I am going to describe damages your retinal cells gradually, not dramatically. There is no single moment of injury. There is no event that trips an alarm. There is just a slow, quiet, cumulative reduction in the number of functional cells at the back of your eye, happening over months and years, below the threshold of a conscious perception, until one day the threshold is crossed and what was reversible becomes permanent. That is the window you are in right now, the window where these habits are still working on you and where changing them still has the power to change the outcome. Here are the 7 habits. The first habit is using screens in complete darkness. You are watching television in bed with the lights off. You are on your phone at 2 a.m. with the room completely dark. You are working on your laptop in a dimly lit room with the screen at full brightness. This is one of the most common and most damaging visual habits in adults over 50, and it is almost universally underestimated. Here is the mechanism. Your visual system is built to process light within a range. When the ambient light in a room is low and a bright screen is the primary light source, your pupils are simultaneously trying to adapt to darkness, while the retina is receiving an intense, concentrated beam of blue-weighted light from the screen. The muscles of the iris oscillate constantly between contracting for the screen brightness and dilating for the surrounding darkness. Over long session, this sustained oscillation drives a level of ciliary muscle fatigue that most people describe as eye strain, headache behind the eyes, or a burning sensation in the lids. But the more significant issue is the retinal exposure to high-intensity blue light in a dark adapted eye. Blue light in the wavelength range of 415 to 455 nanometers penetrates all the way to the retina. In a dark adapted eye, the photoreceptors are more sensitive, meaning they are absorbing more of that light energy per unit of exposure than they would in a normally lit environment. Research has consistently shown that sustained blue light exposure at this level elevates oxidative stress in retinal pigment epithelium cells, which are the support cells underneath your photoreceptors. Chronic oxidative stress in the RPE is one of the primary known mechanisms driving age-related macular degeneration. The correction is simple. Never use a screen as the only light source in the room. Match your ambient lighting to at least 30 to 40% of your screen brightness. Enable a warm light or night mode on all screens after 7 in the evening. If you watch television in bed, keep a bedside lamp on. This single change reduces retinal blue light stress in dark adapted eyes by a clinically meaningful amount. The second habit is not wearing sunglasses outdoors. Most people over 50 own sunglasses. Most of them wear them when it is obviously sunny and bright. What they do not do is wear them consistently on overcast days, during morning and late afternoon hours, in winter, while driving with windows down. This inconsistency produces cumulative UV exposure that adds up to thousands of hours of unprotected outdoor time over a decade. Here is the mechanism. Ultraviolet radiation, specifically UVA and UVB, does not stop at the cornea. It penetrates the eye and reaches the lens and the retina. In the lens, chronic UV exposure drives the cross-linking of proteins in the crystalline lens fibers, which is the primary mechanism of cataract formation. In the retina, UV radiation generates reactive oxygen species, free radicals, that damage photoreceptors and retinal pigment epithelium cells directly. Multiple large epidemiological studies have established that lifetime UV exposure is one of the strongest modifiable risk factors for both cataract development and age-related macular degeneration. The threshold is not bright sunlight. UV radiation is present at significant levels even on heavily overcast days because it penetrates cloud cover. It is present at elevated levels during early morning and late afternoon when the sun is lower on the horizon and UV rays travel through more of the atmosphere at a more direct angle to the eye. It is reflected off water, concrete, sand, and snow, multiplying your effective exposure. The correction is this. Anytime you are outside, you wear UV 400 rated sunglasses. Not fashion sunglasses, not tinted lenses without a UV rating. UV 400 means the lenses block 99 to 100% of UVA and UVB radiation. Wraparound styles offer additional protection from peripheral exposure. This is the single highest return protective investment you can make for your long-term retinal health. The third habit is uncontrolled high blood pressure. This may not sound like an eye habit. It is. Every morning you wake up and take or do not take your antihypertensive medication is a daily habit that directly determines what is happening to the blood vessels inside your eyes. Here is the mechanism. The retina is one of the most metabolically active tissues in the human body per unit of volume. It has an exceptionally dense network of small blood vessels that deliver the oxygen and nutrients photoreceptors need to function. These vessels, precisely because they are small and under continuous pressure, are among the first in the body to show damage from sustained hypertension. Chronically elevated blood pressure causes the walls of retinal arterioles to thicken, narrow, and lose elasticity. This condition is called hypertensive retinopathy, and it progresses through stages from mild arteriolar narrowing all the way to retinal hemorrhages, optic disc swelling, and permanent vision loss. The critical fact is this. Hypertensive retinopathy is largely silent. There are no pain receptors in the retina. There are no early symptoms. Patients with significant retinal vascular damage from hypertension frequently have no visual complaints at all until the damage is advanced. An ophthalmologist doing a dilated fundus exam can see hypertensive retinopathy directly, looking at the retinal vessels through the dilated pupil and grade its severity. Your GP checking your blood pressure cuff number does not give you that picture. Beyond hypertensive retinopathy, sustained high blood pressure dramatically accelerates the progression of age-related macular degeneration in patients who already have early disease. The mechanism is reduced choroidal blood flow. the blood supply that feeds the outer retina, combined with elevated inflammatory markers that are driven by vascular damage. The correction is not a negotiation. If you have been prescribed antihypertensive medication, the habit is taking it every single day without exception. If your blood pressure is uncontrolled and you are not on medication, the conversation you need to have is not with your optometrist, it is with your GP, and it is today. The fourth habit is a diet chronically deficient in lutein and zeaxanthin. These are two carotenoid pigments that your body cannot manufacture on its own. The only source is dietary, and they concentrate almost exclusively in one place in the human body, the macula of the retina. They form what researchers call the macular pigment, a natural yellow filter that sits in front of the photoreceptors in the central macula and absorbs incoming blue and UV light before it can cause oxidative damage to the cells beneath it. The macular pigment is essentially your retina's built-in sunscreen, and like any protective system, it only works if it is adequately maintained. The level of macular pigment in your retina, which researchers call macular pigment optical density, is directly determined by how much lutein and zeaxanthin you consistently consume through your diet. Low macular pigment optical density is one of the most well-established independent risk factors for age-related macular degeneration. The average adult in the United States consumes roughly 1 to 2 milligrams of lutein per day through diet. Research indicates that meaningful protection of macular pigment requires at least 6 milligrams per day, with some studies suggesting 10 milligrams as an optimal intake for adults over 50 at elevated AMD risk. The richest dietary sources of lutein and zeaxanthin are dark leafy greens. Cooked kale delivers approximately 10 to 12 milligrams per half cup. Cooked spinach delivers 6 to 7 milligrams. Raw corn, egg yolks, and orange peppers are also meaningful sources. The bioavailability of lutein from cooked vegetables is significantly higher than from raw, and consuming these foods with a source of dietary fat increases absorption because carotenoids are fat-soluble. The correction is structural, not occasional. Dark leafy greens need to appear in your diet multiple times per week, not occasionally. If dietary intake is consistently insufficient, a supplement containing at least 10 milligrams of lutein and 2 milligrams of zeaxanthin daily is a reasonable adjunct, and it is the basis of the AREDS2 formulation that has a clinical trial evidence behind it for AMD risk reduction. The fifth habit is smoking, or having smoked and not understanding the ongoing risk. This one requires no nuance. Smoking is the single most powerful modifiable risk factor for age-related macular degeneration. The data on this is not contested. Current smokers have a 2 to 4 times higher risk of developing AMD compared to non-smokers. Former smokers carry a risk that remains elevated for years after cessation, though it does decline over time. The mechanism operates through multiple pathways simultaneously. Cigarette smoke generates an enormous oxidative load that depletes antioxidant defenses throughout the body, including in the retina. It reduces choroidal blood flow, cutting the oxygen supply to the outer retina. It increases levels of inflammatory cytokines that are directly implicated in AMD pathology. It accelerates the accumulation of drusen, the waste deposits that build up under the retinal pigment epithelium and mark the earliest structural stage of AMD. It also degrades macular pigment, further reducing the retina's natural protection against blue light. If you currently smoke, the most impactful single decision you can make for your long-term vision is cessation. If you're a former smoker, the habit now is supplementing with the nutrients that smoking depleted and maintaining scrupulous UV protection, because your retinal risk remains elevated even after you stopped. The sixth habit is skipping annual dilated eye exams. This is a habit of omission. Every year that passes without a dilated fundus exam from a qualified ophthalmologist is a year during which early retinal changes, early drusen formation, early macular pigment thinning, early hypertensive retinopathy, early glaucomatous optic nerve changes can progress undetected and untreated. The key word is dilated. A standard vision test at an optometrist measures your refractive error, how well you can read the chart. It does not provide a direct view of the retina. A dilated fundus exam requires pupil dilation with eye drops, after which the ophthalmologist can view the entire retinal surface directly, including the macula, the optic disc, the retinal vessels, and the peripheral retina. This is the only examination that allows direct visualization of the structural changes that precede symptomatic vision loss. The recommendation from major ophthalmological bodies is a comprehensive dilated eye exam every 1 to 2 years for adults over 50 with no known risk factors, and annually for adults over 50 who have any of the following: a family history of macular degeneration or glaucoma, a diagnosis of hypertension or type 2 diabetes, a history of smoking, or documented early AMD changes from a previous exam. The correction is a calendar entry. After this video, you schedule a dilated eye exam with an ophthalmologist if you have not had one in the last 12 months. When you call to book, you use these specific words: I would like a comprehensive dilated fundus exam, and I would also like OCT imaging of the macula. The seventh habit is sleeping fewer than 6 hours per night consistently. Sleep deprivation is not typically discussed in the context of eye health. It should be. Sleep is when the eye and the visual system perform critical maintenance functions that cannot happen while you are awake. During sleep, the rate of aqueous humor drainage in the eye is altered in ways that allow intraocular pressure to cycle through its normal range. In people with early glaucoma risk, consistently disrupted sleep patterns are associated with less favorable intraocular pressure profiles. The glymphatic system, the brain's waste clearance system, operates primarily during deep sleep. The optic nerve and the visual cortex are both part of the central nervous system, and the metabolic waste products that accumulate in neural tissue during waking hours are cleared during sleep. Chronic sleep deprivation means chronic inadequate clearance, which contributes to the inflammatory environment that accelerates age-related degeneration throughout the neural visual pathway. There is also a more immediate and widely experienced consequence. Chronic sleep deprivation significantly worsens dry eye syndrome, which is already more prevalent in adults over 50. Incomplete eyelid closure during poor sleep, reduced blink rate during waking hours from fatigue, and altered tear film composition from sleep disruption all converge to produce chronic ocular surface inflammation. Dry eye that is dismissed as a nuisance is actually a source of persistent low-grade corneal stress that, in the context of other risk factors, compounds overall visual health decline. The correction is treating sleep as a clinical priority, not a lifestyle preference. 7 to 8 hours of consolidated sleep per night is the evidence-based target for adults over 50. If you are consistently falling short of 6 hours, that is a conversation to have with your GP about what is driving it and what can be done about it. Let me now bring all 7 habits together clearly. Using screens as your only light source in the dark room. Producing chronic blue light stress on dark adapted retinal cells. Skipping sunglasses outdoors consistently. Accumulating UV damage to the lens and macula across thousands of unprotected hours. Letting blood pressure go uncontrolled. Silently damaging the small vessels that supply your retina every single day. Eating a diet chronically deficient in lutein and zeaxanthin, leaving your macula without the nutritional raw material for its own protective pigment. Smoking or carrying the residual risk of former smoking without addressing it nutritionally and clinically. Skipping the annual dilated exam, allowing early structural changes to progress through the years when intervention is still effective. And sleeping fewer than 6 hours per night, depriving the visual system of the maintenance window it requires to manage inflammation and waste clearance. None of these cause a dramatic event. All of them are cumulative. All of them are measurable. And all of them are still within your power to change. Here is what you do after this video. First, tonight, if you're going to watch television or use a screen after dark, turn on the lamp. Enable warm light mode on your phone and laptop. This costs you nothing and starts reducing your retinal blue light burden immediately. Second, this week, find your sunglasses. Check that they carry a UV 400 rating and commit to wearing them every time you go outside, regardless of cloud cover. If they are not UV 400 rated, replace them. Third, this week, look at your diet. Identify where you can add dark leafy greens 2 to 3 times per week. If that is not realistic for your current eating pattern, research an AREDS2 formulation supplement and discuss it with your doctor. Fourth, if you have not had a dilated fundus exam in the past 12 months, call an ophthalmology practice this week and schedule one. Ask specifically for a dilated exam and OCT imaging. Fifth, if you are on blood pressure medication, take it today and every day. If you are not, and your blood pressure is elevated, make a GP appointment. The healthcare system is excellent at treating vision loss once it arrives. It is not structured to teach you what is creating it. An appointment that prevents a problem does not generate the downstream revenue that treating the problem does. That is simply the reality of how the system is built. It is not a conspiracy. It is an economic structure, and it is the reason this channel exists. Subscribe to Dr. Rubens Senior Health and hit like. Drop your age in the comments below. It tells me exactly who is watching this and where to focus the content that will actually help you most.